Calcium isn't just about strong bones and teeth. It plays a crucial role in what I call the three Bs: brain, bone, and blood. Calcium is essential for nerve impulse and muscle contraction. It is also important for bone strength and bone structure. And it is also important for coagulation. In this illustration, the FT means the firing threshold. If the stimulus reaches the threshold, an action potential occurs. Therefore, nerve fires an impulse. If a stimulus does not reach the threshold, no action potential is generated. In hypocalcemia, nerves and muscles becomes overexcited. Why? Because hypocalcemia lowers the action potential threshold, making neurons fires excessively, resulting to muscle spasms, painful cramps, and tetany. In hypercalcemia, nerves and muscles become sluggish. High calcium level in the body raises the threshold, meaning a stronger stimulus is needed to reach the threshold and generate an action potential. Meanwhile, normal or usual stimulus will not reach the threshold, therefore leading to weakness and sluggish reflexes. For bone strength and structure, 99% of calcium is stored in bones. Hormones regulating calcium includes PTH and calcitonin. First, let's discuss calcium homeostasis. The parathyroid glands reacts through a negative feedback loop to regulate homeostasis. When blood calcium levels drop, the parathyroid glands detects this and release parathyroid hormone. Conversely, when calcium levels are high, PTH secretion is suppressed to prevent excessive calcium accumulation. In hypocalcemia, PTH stimulates osteoclast activity, which breaks down bone tissue and releases calcium and phosphate into the bloodstream. This process is known as bone resorption. This increases circulating calcium levels while also increasing phosphate release. Remember, PTH, bone to blood. In the renal tubules, PTH promotes calcium reabsorption, preventing calcium loss through urine. PTH also enhances the excretion of phosphate, preventing calcium from binding with phosphate and forming insoluble deposits, ensuring more free calcium remains in circulation. PTH stimulates the conversion of inactive vitamin D into calcitriol. Active vitamin D increases calcium absorption in the small intestines, allowing dietary calciums to enter the bloodstream more efficiently. In cases of post-thyroidectomy, the parathyroid glands may be removed or damaged, leading to low PTH production. We call this as hypoparathyroidism. This results to lower osteoclastic activity, which means decreased bone resorption. Therefore, low calcium is present into the blood. Calcium reabsorption by the kidney is reduced. More calcium is lost into the urine. There will also be decreased vitamin D activation, leading to poor calcium absorption in the gut. In cases of overactive parathyroid glands or primary hyperparathyroidism, excess PTH production leads to excessive calcium release from bones. In hyperparathyroidism, bones will be weaker and fragile. Since calcium is also reabsorbed by the kidneys, there is an increased risk for kidney stone formation. Another hormone works to decrease blood calcium levels. When blood calcium rises above normal, parafollicular cells in the thyroid gland secrete calcitonin. This inhibits osteoclast activity, speeds up calcium uptake by the bones. The net result is that CT promotes bone formation and decreases blood calcium levels. Despite these effects, the role of calcitonin in normal calcium homeostasis is uncertain because it can be completely absent without causing symptoms. Nevertheless, calcitonin, or mycalcin, from salmon is an effective drug for treating osteoporosis. One of the common causes in hypocalcemia is kidney disease. When the kidneys fail, phosphorus level rise, binding to calcium and lowering its availability. Vitamin D activation is also affected. Another is hormonal imbalance, especially in conditions like hypoparathyroidism. Gastrointestinal disorders that also leads to vitamin D deficiency, such as Crohn's or celiac disease, may have an impact to low calcium levels. Calcium loss can happen due to certain medications like diuretics. On the other hand, we have hypercalcemia. One major cause is hyperparathyroidism. In some cases, cancer can lead to bone destruction, releasing large amounts of calcium into circulation. Certain medications such as thiazide diuretics, excessive vitamin D, or calcium supplements can also contribute. In the skeletal muscles, hypocalcemia lowers the activation threshold, meaning nerves fires too easily. This leads to tetany, cramps, and muscle spasms. On the flip side, hypercalcemia raises the activation threshold, making muscles harder to stimulate. The result, muscle weakness and decreased deep tendon reflexes. Calcium imbalances leads to irregular rhythm. In hypocalcemia, there is prolonged QT intervals and ST segment. Just remember, pro-cats. Hypo sounds like pro-cats. In contrast, hypercalcemia leads to widened P waves and a shortened ST segments. Memory trick, wet shorts, widened P waves and shortened ST segments. Calcium also affects smooth muscles. Low calcium makes the smooth muscle active, which results to increased contraction. Blood vessels becomes narrow or constricted, which may lead to high blood pressure. The airway may be narrowed, leading to bronchospasms that can block the airway. When stridor is present, it is a medical emergency, so always remember that the trach set and calcium gluconates are prepared. An overactive gut causes diarrhea and cramping. But with too much calcium, everything slows down. Blood vessels dilate, dropping blood pressure, breathings may become sluggish, and constipation may occur. Calcium plays a major role here. Too much calcium increases the risk of excessive clotting, while too little makes bleeding more likely. When calcium imbalances occur, especially with hypercalcemia due to bone breakdown, the structural integrity weakens, leading to pathological fractures, where bones breaks without significant trauma. Nursing responsibility here is fall prevention, assist patient in ambulation and move slowly. The footwear of the patient should be non-slip. The goal in hypocalcemia is simple: increase calcium availability through additional intake. Vitamin D is also important, along with sunlight exposure for natural vitamin D synthesis. In some cases, high phosphate levels may be causing calcium depletion, so we use phosphate binders to prevent calcium loss. In hypercalcemia, we need to reduce intake. Diuretics are also used but not thiazides. They should be taken in the morning to prevent sleep disturbances from frequent urination at night. IV phosphorus or calcium binders to help regulate calcium levels. In cases where bone breakdown is the cause, we rely on biphosphonates, dose-ending indronate medications, to strengthen bones and prevent further calcium release. IM calcitonin can quickly lower blood calcium levels. In severe cases, dialysis may be required. And that's a wrap, future RNs. Follow NURZ VHub for more smart study guides.